a last but one question. This is on DAPT, the present concept. Is it going to be a tailor-made therapy? To take up this issue is Dr. Rishi Sethi, and to chair the session, we have Dr. V.S. Narayan and Dr. Arup Das Viswas. Hello, Sangatavelu. Good evening. Good evening.
Good evening.
Good evening. Just be logged in for a few minutes. The next session is yours.
Sure.
Rishi, are you here?
Yes, sir.
Sengo, nice to see you. Sengo, nice to see you. How are you?
Nice to see you. Fine, nice to see you.
Rishi, you start sharing the slides. The discussion will be at the end.
Sure. Well, most eminent chairperson, most senior members on the panel, colleagues, ladies and gentlemen, my job today is to discuss with you all the present concepts in dual antiplatelet therapy, and then trying to answer a specific question that can dual antiplatelet therapy be tailor-made for an individual, and what can be the factor that could be used in tailor-making the therapy. So we all are aware that platelet adhesion, activation, and aggregation are integral component of arterial thrombosis in all acute coronary syndrome. Therefore, antiplatelet therapy is of pivotal role in all patients of acute coronary syndrome and all patients who undergo coronary stenting and coronary angioplasty. And just because there are multiple signal pathways and we need an adequate platelet suppression, therefore dual antiplatelet therapy that consists of aspirin as well as one or the other of the P2Y12 inhibitor is mandatory, at least for some duration, in all patients who suffer acute coronary syndrome or undergo coronary angioplasty. So I wanted to say by this slide that while most of the drugs that are used in cardiovascular medication, be it beta blockers or ACE inhibitors or statins, have got multiple pronged action on various systems and various tissues of the body. Whereas antiplatelets are very specific in their action, they just inhibit platelet activation, and therefore, more potent the drug antiplatelet action would be of any drug, it would cause to lowering of ischemic events. At the same point of time, it will cause more bleeding events. And this is important when we analyze different trials of antiplatelet therapy, whereas there are many ways in which beta blockers or statins can affect cardiovascular system. There are many mechanisms where beta blockers can have an influential effect on heart failure, for say. But when we are comparing different trials of antiplatelet therapy, then it's just the antiplatelet action and then very little beyond antiplatelet action. For example, just in ticagrelor, for example, that has some effect on adenosine, about which we will be discussing, but predominantly it's the antiplatelet action alone that should be discussed. And we will come to this point, why I am highlighting this point later in my talk. So whenever we use any antiplatelet, and especially dual antiplatelet therapy, the predominant question that we have to address is how do we balance the ischemic endpoints along with increase in the bleeding. So we know that whenever we use a drug which is more potent, it will lead to a decrease in the ischemic events, for example, MIs and stent thrombosis and ischemic strokes. But at the same point of time, it will give rise to increased bleeding. So what is the sweet spot when we achieve the maximum decrease in the ischemic endpoints, at the same point of time have an acceptable level of bleeding? And this sweet spot is really the question, the core question behind all antiplatelet therapy and all approaches to antiplatelet therapy. Right from the time Cure and Commit came in 2000, early 2000s, the dual antiplatelet therapy has been the forefront of the anti-ischemic and the therapy for post-PCI patients. And then they started with clopidogrel, and in 2007 to 2010, Triton and Plato came. And thereafter, many trials have come, each trying essentially to address the simple question that what are the agents that can be used as part of the dual antiplatelet therapy, what can be the duration of the therapy, how can we mix and match to achieve the sweet spot where there is a decrease in the overall ischemic events, but at the same point of time, also an acceptable breathing. So the fundamental question that we need to answer today as we move forward in this talk is that which agents can be used as a part of the dual antiplatelet therapy combination? Is there a difference between the various combinations? And we all know most of what is need to be known. I think all of us are on one page on this, but still we'll try to dig up some data and try to refresh our memories. Then the second question that we want to answer is that when to switch to monotherapy. Should it be 1 year, 1 month, 3 months, 6 months, 1 year or beyond? And when we shift to a monotherapy, which is an agent, is it imperative only to use aspirin as monotherapy? Or as monotherapy, when we shift from dual antiplatelet to a monotherapy, we can use other agents, for example, ticagrelor. And the final question that we need to answer today, that's the specific question, is can we tailor the therapy for individual patients based upon various clinical or biochemical or genetic parameter that are specific to that individual? So these three fundamental questions we would like to answer today. We all know about all the three P2Y12 inhibitor, clopidogrel, prasugrel for ticagrelor, but just for the benefit of the audience, clopidogrel is a little slow in onset as compared to a little less potent as compared to the other two agents. It takes around 2 to 8 hours after loading to get into action, and the steady antiplatelet activity is to the tune of 40 to 60%. The prasugrel and ticagrelor, on the other hand, are much faster in action, 30 minutes to 45 minutes from their loading dose, and their peak antiplatelet activity is around inhibition of platelet activity to around 70 to 90%. And all of us have accepted that the 70 to 90% bracket of a steady state antiplatelet activity is actually the point where you get maximum reduction in ischemic events and the bleeding is more or less acceptable. The ticagrelor is a little different from the other two compounds because it's the only agent which is not a prodrug. It is reversible in action, so its onset and offset and action is switch on and switch off, and it needs to be given BID doses. Another highlighting point, so-called the pleiotropic effect, which I talked earlier, that antiplatelets are very focused in their action on inhibiting only the platelets, but it's ticagrelor that has got some additional action, that is its ability to increase the adenosine, overall adenosine levels in the body, which may be responsible for the pleiotropic, so-called pleiotropic effects of ticagrelor in terms of plaque stabilization, increase adenosine-induced coronary blood flow, and improvement in endothelial function. At the same point of time, this increase in adenosine leads to the side effect of dyspnea and a little bit of AV blocks that we sometimes see in ticagrelor. So this particular advantage of ticagrelor was the thing people were saying, that ticagrelor can be used in medical management of acute coronary syndrome and in acute MI patients more than prasugrel because of these sort of additional effects it had beyond antiplatelet. But whether or not it was proved in clinical trials or whether the story was completely reversed, this we'll come to know as we move forward. So the first question to answer was that when these new antiplatelets of ticagrelor and prasugrel came, were they superior to clopidogrel? And it was clearly shown that both these agents were superior to clopidogrel in terms of ischemic endpoints, prevention in Triton trial and in Plato trial, and it had acceptable bleeding. So we started to use and started to believe that in acute coronary syndrome patients, we should be preferentially using ticagrelor and prasugrel instead of clopidogrel, whether it be acute coronary syndrome or acute coronary syndrome going in for coronary angioplasty. The little difference was that since in the inclusion trial of Plato, we had Triton TIMI, it was only the prasugrel was used only in those patients who were undergoing PCI. So it was prasugrel was not to be used in medical management, while as ticagrelor can be used both in the medical management as well as those patients of acute coronary syndrome who were going in for coronary angioplasty. And based upon the findings of Plato trial and the Triton TIMI 80 trials, although they were different trials, the overall impression came out that ticagrelor is a little superior to prasugrel. Both are of similar efficacy. That was the impression that came out. Both were of similar efficacy in terms of ischemic and bleeding risk. And ticagrelor was a little superior, that it can be used in a broader spectrum of patients who were more than 75 years of age, who were fragile, less than 60 kgs, who had prior ischemic stroke or TIs. And it can also be used in the medical management of acute coronary syndrome, whereas prasugrel could not be used in all these conditions because they were exclusion criteria of the Triton trial. The only disadvantage of ticagrelor for all of us was that it was costly. It was supposed to be given in BID dosage, and it had, in a significant percent of patients, reduced the side effect of dyspnea, which was very confusing, especially after acute coronary syndrome. But we know that we cannot compare two drugs based upon their different results or different actions in different trials, because the patient subset may be entirely different. And for that, you need a head-on comparison. The head-on comparison started coming. The first one was Prague 18, where prasugrel and ticagrelor were compared head-on for all those patients who were going for primary angioplasty. And as expected, because their antiplatelet efficacy was similar, the Prague 18 results was that both prasugrel and ticagrelor were similar in action, and they had similar bleeding profile. Then it was a subject of a meta-analysis, and the meta-analysis also went on to say that ticagrelor and prasugrel were exactly similar in action in acute coronary syndrome in patients undergoing PCI. So everything was going, story that was going was absolutely smooth way. It was going as per the logically we were believing, and it was going as per the pharmacological basis of the trial. But the problem started happening when the ticagrelor started becoming off-label, and there was more interest in prasugrel. And then we all know the trial came ICER-REACT that actually said that when we head-on compared ticagrelor and prasugrel in acute coronary syndrome going for coronary intervention, prasugrel was clearly superior to ticagrelor now, and it was showing more decrease in ischemic endpoints in stroke and MACE, and the bleeding rates were near about similar. So if the bleeding rate was similar and prasugrel was showing equal amount of reduction in ischemic endpoints and MACE, then this was now supposed to be the drug of choice in place of ticagrelor in this condition. So here the story started to divert a little bit. And when the same question was put to a meta-analysis that was published this year, it again said the same thing, that prasugrel, when we study all the clinical data that is available in acute coronary syndrome going for PCI between head-on comparisons of clopidogrel and of prasugrel and ticagrelor, then prasugrel is superior to ticagrelor. So that's how all this started coming. And although ICER-REACT came after these guidelines, but the last official guidelines of 2017, I would like you to focus only on class 1 indication. And the class 1 indication here were that in medical therapy, there was no role for dual antiplatelet therapy for stable coronary artery disease, but in acute coronary syndrome, dual antiplatelet therapy with ticagrelor or clopidogrel, not prasugrel here, extreme on the right side panel. It can be given, and it should be given, for 12 months duration. That was for medical treatment of acute coronary syndrome. Coming to the extreme left-hand side, when we were doing PCI for stable coronary artery disease, dual antiplatelet therapy as a class 1 indication needed to be given for 6 months. And here, only clopidogrel was the drug of choice along with aspirin, and not prasugrel and ticagrelor. And when PCI was done for acute coronary syndrome, then the duration of the dual antiplatelet therapy was 12 months. And here the agents were prasugrel and ticagrelor, both was superior to clopidogrel and should have been preferred to clopidogrel in this particular setting. So this was class 1 indication. But subtly hidden in this flowchart are also class 2B, 2C indications marked in yellow here. And here they say that if the patient has got high bleeding risk, then probably the duration of the antiplatelet therapy can be shortened. Although the drugs remain same, but the duration of antiplatelet therapy can be shortened to 1 month or 3 months or 6 months, depending upon various clinical scenarios. So clearly, the churning of thought process was that based upon the patient's bleeding risk, that means taking patients' individual clinical characteristics into consideration, we could shorten or tailor-made therapy for an individual patient. So some churning of this tailoring of thought of antiplatelet therapy was already coming. The new knowledge that came after these guidelines, along with ICER React 5, were crucial in forming this concept, and that is the main point of our discussion today. And that is that when we take the patient's clinical characteristics into picture, the first thing and the most important thing that we have to consider is his ischemic risk and his bleeding risk. The bleeding risk is calculated by the DAPT score or the precise DAPT score. They are not similar, they are quite different score, whereas the DAPT score that were used in earlier studies was to be used after 12 months of uneventful DAPT therapy to make a decision whether we want to continue the DAPT beyond 12 months or not. So that was the use for the DAPT score. But the precise DAPT score was developed to be used prospectively during the time of angioplasty, during the time of index event. It had hemoglobin, WBC, age, creatinine clearance, and the history of prior bleeding. And according to that, a score was calculated. If the score was less than 25, then it was a standard or low-risk patient. And here, the standard or a long-term dual antiplatelet therapy for 12 months or even longer could be given. But if the precise DAPT score was greater than equal to 25, these patients were presumed to be of high bleeding risk. And here, a shorter duration of dual antiplatelet therapy, 6 months, 3 months to 6 months, was advocated. So this was the score that was developed. But when this score was prospectively studied, I would say not prospectively, but studied in a large clinical study, it was a study in which the precise DAPT score was applied retrospectively to 14,000 patients of previous studies. And it was seen that when we apply the score, then short-term dual antiplatelet therapy reduced bleeding risk without compromising on ischemic risk in patients with high bleeding risk scores, that is risk scores, precise DAPT scores of greater than equal to 25. So for the first time, we were definitely calculating bleeding risk or things otherwise, but somehow utilizing individual patients' clinical data, we were trying to tailor the therapy of how long the dual antiplatelet can be given, and that was proved retrospectively in the precise DAPT study. This was a smaller Japanese trial, STOP DAPT, in which stopping DAPT at 3 months in selected patients after a cobalt chromium everolimus eluting stent was at least as safe as a prolonged DAPT therapy, the standard DAPT therapy from historical control. This was a small trial. But the real beautiful trial came, which was the Twilight Trial. We discussed in Professor Guha's presentation in the morning also. This was a brilliant trial, and I think all of us must go into a little bit of a detail of this trial design. It was a brilliantly designed trial, the Twilight Trial, in which high-risk patients of PCI, and we will come to the high-risk patients, were enrolled and were given dual antiplatelet therapy of aspirin plus ticagrelor for 3 months. At the end of 3 months, if there was no event, these patients were then randomized to receive either the standard therapy of ticagrelor and aspirin for next 12 months or ticagrelor alone for next 12 months. So firstly, it was using clinical parameters to randomize the patients, and these parameters had to be high-risk PCI in terms of high-risk bleeding parameters of clinical criteria of age more than 65, female, gender, and so on and so forth. And the angiographic criteria also, at least one clinical criteria and one angiographic criteria had to be fulfilled before the randomization of these patients. And angiographically also, these patients were of high ischemic risk in terms of multivessel disease, left main, Alzheimer's disease, and so on and so forth. So the first point was that it was using clinical data and angiographic data to randomize the patient and deciding which therapy should continue. And it was also a trial which was revolutionary because when coming to monotherapy, it was using ticagrelor, whereas most of the time when we go for monotherapy, we use plain and simple aspirin. And it was seen that when we use this kind of segregation, stopping the dual antiplatelet and continuing only ticagrelor, it was beneficial both in terms of a reduction. It was beneficial in terms of reduction of bleeding risk in these patients, while as the cumulative incidence of MACE did not differ. So when we started using clinical parameters, the angiographic parameters of the patient, we were somehow be able to decide which drug to be given, when the dual platelet therapy can be stopped, and so on and so forth. Now started coming the science of precision cardiovascular medicine. And that was, can we use the genetic data along with the clinical data to combine the two and have a specific target therapy in different patients? So, and it can be, the precision cardiovascular medicine can have many inputs going into decision making, but let's strict ourselves to the genetic for today. And here multiple genes were studied, but the CYP2C19 gene was the gene that caused that caught everyone's attention. If it was a mutation in this particular gene, it was causing clopidogrel resistance in the patient. And gene analysis was always thought to be a cumbersome process, so people were not using it. But then point of care assays were developed that could give you bedside report of this gene testing of the CYP2C19 gene mutation in 1 or 2 hours, and thereby helping you making the clinical decision in a simple and early way. And then the first trial to address this kind of genetic analysis and trying to tailor the therapy according to this genetic analysis was the Tailor-PCI trial, in which around 5,200 patients were randomized to a conventional arm, who were given clopidogrel for 1 year. And after 1 year, genetic analysis was done, and only those patients who were resistant to clopidogrel by the mutation of the CYP2C19 gene were included in the study. Only these patients were included. On the other hand, in the prospective arm, genotyping was done at the onset, and all those patients who were clopidogrel resistance, were given ticagrelor from start itself. And the comparison was made only between these two arms, in which clopidogrel was given or ticagrelor was given in the genetically resistant patients who had genetic resistance to clopidogrel. So the results were promising and not also. They did not achieve statistical significance because they set out a target of a 50% decrease in overall clinical events. They did not achieve a 50% decrease, but they did achieve a 34% decrease in the genotype-guided therapy. In the prospectively genotype-guided therapy, there was a 34% decrease in overall clinical outcomes, thereby setting the tone that genetic testing can be used as part of tailoring the therapy of antiplatelet therapy and dual antiplatelet therapy. So this was the hypothesis-forming trial, and it was further studied in the popular genetic study, which was again a great study, because every time we think about clopidogrel resistance and trying to find clopidogrel resistance by whatever means possible, the biochemical tests, the clinical tests, the clinical history, or the genetic analysis, a question always comes to our mind. Why do we bother about all these things? Why not just give the stronger drugs of ticagrelor or prasugrel to all patients? The answer is no, because when we start to do it, when we start in trying to do this, then what will happen is that probably the cost will increase and the bleeding rates will also increase. And bleeding is not something that we can take lightly at the cost of just having better clinical outcomes in terms of ischemic. Sorry. So popular genetic was a brilliant disease. Again, around 2,700 patients were randomized. The standard arm received ticagrelor as part of the dual antiplatelet therapy for 1 year. It was the standard arm received ticagrelor, while as the genotype arm now had it tested for the genome analysis, and those patients who were resistant to clopidogrel were given ticagrelor here also, and those patients who were not resistant to clopidogrel were continued on clopidogrel. So in the genotype arm, patients got both clopidogrel as well as ticagrelor arm, whereas in the standard arm, every patient got ticagrelor, and it was seen that both the primary endpoints and the primary bleeding endpoints were lower in the genetically decided patients. So it's not still bedside now. We are not using it on a daily basis, but certainly the clinical parameters and the genetic parameters now are being used more and more, at least in experimental drugs, to try to tailor-make therapy for acute coronary syndrome and post-PCI care in terms of dual antiplatelet. I would like to conclude by saying that dual antiplatelet is the cornerstone of therapy in both acute coronary syndrome and post-PCI care. The choice of agents and the duration of therapy should be made judiciously, taking into many consideration, and rather than applying a blanket guideline for all patients, tailoring the therapy based on the clinical, biochemical, or genetic parameters may become the norm in times to come. I thank you for the opportunity and thank you for your attention.
Thank you, Dr. Rishi. I think that was a brilliant talk and very absorbing. And you took us through the entire journey of how the antiplatelets came in and how we should now be thinking about using them. Just wanted to say that if we depend on the Twilight results, it's a brilliant study, why not keep things simple? Do nothing, do no genetic testing, because you know the paradox about genetic testing also, despite that you have a genetics which tells you against the usage of clopidogrel, using clopidogrel will not make a difference clinically. So that's the paradox. So why go in for all this and just take up 3 months of dual therapy with aspirin, ticagrelor, and then continue ticagrelor for 12 months or beyond, going by the Pegasus. So why not keep things simple rather than deciding whether to use clopidogrel or to use ticagrelor or to use prasugrel? That we would want to know. I would at least want to know. And the second thing, I would like you to tell us something about de-escalation of therapy, because a lot of our patients will not tolerate ticagrelor or prasugrel. So how about getting them down from ticagrelor to prasugrel to clopidogrel, and what are these patients which you think should be de-escalated?
So coming to the first point is that all these thought processes have been running in parallel for the last 2 or 3 years. All these trials are running in parallel. The Twilight is running in parallel with the genetic trials, and the therapy is now. I would completely agree that if it is not based upon the Twilight results, and if the genetic testing is not available, and if the patient is high risk also, then 3 months of dual antiplatelet therapy and continuing with a more potent agent seems to be a reasonable choice. But before Twilight came, this sort of combination, use of this combination, we had no clinical data to use that. Now we have clinical data also to use that. And all these thoughts are running in parallel, and we all would be wiser in times to come where we would find the common meeting ground. And I think it would be like, sometimes, we can argue that in those patients, even if you take Twilight Trial, and if you take those patients that were given ticagrelor for the next 9 months, had we used genetic testing at that point of time, maybe 80% of them would have got clopidogrel and sustained themselves in a much better way with less bleeding risk. So we don't know that answer as it is. So
can we have some comments from my co-chair on that?
Yeah. Good evening. Actually, I was having some problem in the speaker system. Now I'm okay. And thank you and congratulations, Dr. Rishi. I'm Dr. Dazifas calling. So basically, you have shown by various trials the pendular swing between the choice of drugs, clopidogrel, ticagrelor, prasugrel, that has been beautifully exposed. And a basic message has been, your talk has been, if the simple gun is sufficient, don't go for the cannon, so that the people are less injured. Now, Dr. Narayan was speaking in the same tune. If we don't have the scope of measuring the genetic properties, then whether on clinical grounds we can go for choosing the drug and choosing the duration of therapy at the present moment.
So at the present moment, although the guidelines have not yet reached there, but given the Twilight results, if the patient is high risk, both in terms of high clinical risk, in bleeding risk or ischemic risk, if the patient is high risk, then it is much judicious to use a 3 months duration. As the Twilight results says, 3-month duration of dual antiplatelet therapy and continuing the monotherapy with ticagrelor rather than aspirin for the remaining part of 1 year.
And do you think the presence of diabetes, hypertension, obesity, these factors, and also the stent that has been put in, they modify the choice?
Yeah, on that note, I would just like to answer what I asked Dr. Rishi on the de-escalation part, because a lot of our patients will say that we want to take off ticagrelor and there are some side effects also. So there are certain patients where you would discourage that, and those are the patients which Dr. Biswas talked about, the ones who are diabetics, who have renal dysfunction, who have long stents, who have small arteries, small stents, who have had some event in the past, and who have a bigger chance of getting a stent thrombosis. So all these patients you will not like to de-escalate. Otherwise, you sometimes have to listen to the patient's complaint and try to get down from ticagrelor to a more friendly, pocket-friendly as well as side effect-friendly clopidogrel. But all those conditions you would discourage the usage back from ticagrelor to clopidogrel, which I just mentioned. Any other comments from our colleagues? And otherwise, we can close the section, taking permission from Dr. Guha.
I think it was a wonderful talk, and
Yeah, I think so.
interaction was also very good. Thanks, Rishi, and thanks, Dr. Narayan and Arubda.
And let us be a give hand. This sound was not hard for this whole day.
So